Welcome to AETCM, the emergency medicine channel. Shall we
Yes.
start?
Yes.
49-year-old male came to ER with complaints of one episode of generalized tonic-clonic movements of all four limbs, followed by confusion for 10 minutes. On initial 10-second assessment, patient was conscious and oriented, airway patent, no pooling of secretion. Breathing, respiratory rate was 14 rate per minute, SpO2 97 in room air. Circulation, BP was 120/80, heart rate was 98 beats per minute. On disability, GCS was E4, V5, M6. Pupils were equally and bilaterally reactive. GRBS was 1
What is the
1.
importance of pupil in trauma?
In anisocoria can indicate IC bleed. And if a patient is under the influence of any
Alcohol.
alcohol or drugs.
Okay.
GRBS was 112 mg per day. Exposure, patient was febrile. Adjuvants to primary survey, we took in VBG showing lactate of 5.8. Sodium was 138, potassium 4.1, ionic calcium was
What is the importance
118.
of sodium in raised ICT or head injuries or
Hyponatremia or hypernatremia can cause.
Yamini? What is the importance of sodium?
So because of we can use increase the level of sodium and increase the osmolarity of the CSF, and we can try to reduce the water content.
So it is our duty to increase the sodium levels in the blood to reduce the raised ICT. Okay, but initially nothing will happen. It may be slightly lower. Okay, but during the course of treatment, you are supposed to increase the sodium if there is a raised ICT.
Coming to sample history, a 49-year-old male came to ER with one episode of generalized tonic-clonic movements of all four limbs associated with uprolling of eyes and frothing from mouth, post which he had an postictal confusion for around 10 minutes. Patient had history of alcohol intake 12 hours back, no history of tongue bite, bladder bowel incontinence, no history of fever with altered sensorium, no history of vomiting, headache, blurring of vision. Patient is a known case of substance use disorder since last 12 years. Patient had an history of RTA 2 years back, post which patient had a frontoparietal
What are the
SDH.
substance use or misuse can induce seizure? What are the reasons for that?
It can reduce the seizure threshold and
It can reduce the seizure threshold means
it can actually seizure is a neuronal disturbance caused due to excessive electrical discharges in the brain. These
so you take morphine, pethidine,
codeine.
tramadol, all these things will they produce seizures?
Not in all the
Amphetamine and all can produce because stimulants can produce seizure, but the suppressants will not produce seizure. But most of the drug abusers are taking suppressants. Some are, other one is very costly, so they are not routinely used, but it is used. So what do you think? The suppressants like morphine, pethidine, tramadol, these things are commonly used, drug abusers. What do you think is the reason for seizure? What do you think?
Seizure level is reduced.
Threshold is reduced by stimulants. Suppressants? Sorry. They reduce reduced. So there will not be any. No. So you give diazepam to a patient. Seizure threshold actually it is going to increase so that seizure will not happen. So when the patient is taking tramadol, pethidine, morphine, all these things, seizure will not happen because you are suppressing the brain. But when this patient develops seizure, that is the question.
The toxic metabolites.
withdrawal can cause.
So that is the answer. So whenever the patient is having high levels of all these things, patient may not have seizures. Okay, but suddenly if the patient is not getting these suppressants, the seizure activity, that time the seizure threshold increases and patient throws the seizure. So we have to be very careful taking history. If the patient is on some type of drug abusing drugs, then suddenly withdrawal of that drug, including alcohol, can produce seizures.
Post the RTA, patient had a frontoparietal STH and status post decompressive craniotomy, and he developed his first seizure post 6 months after his surgery, and patient was already on Levipil 500 mg BD.
Levipil is levetiracetam.
Levetiracetam.
What are the indications of levetiracetam?
It's a broad spectrum.
Nowadays we are using levetiracetam
yeah,
for all patients.
The complete mechanism is not known, but
Okay.
usually it is a broad spectrum
That also I
antiepilepticus.
understood. Why it is gaining more and more like users?
Less side effects compared to other.
What are the major side effects of other drugs? Phenytoin, phosphonatoin, phenobarbital.
Can cause hypotension, cardiac suppression,
Okay. They
respiratory.
can produce some arrhythmias then.
All this benzodiazepines can cause
Some respiratory depression, but they will never produce respiratory arrest. They produce depression. What is more important than all these things? It is all correct. What you told is correct. One more problem: the phenytoin, phenobarbital. These drugs cannot be used in one condition. What is that condition?
Porphyria.
Porphyria, you cannot use all these things. But that is not very common disease, but you are right. What is common? And that produces both, its effect and withdrawal can produce seizures, and it produces some liver injury. So you cannot use phenytoin, phenobarbital in that condition. What is that? It is very, very common. Alcohol. Alcoholic hepatitis or chronic liver disease. When the liver is damaged, you cannot use phenytoin, phenobarbital, all these things. That's why this is gaining more and more popularity. Okay, the side effects as such is very less, and arrhythmias, all these things are very less. And chronic liver disease or liver injuries, also this is can be safely used.
Post-traumatic seizure is defined as a recurrent seizure disorder secondary to any traumatic brain injury. It can be divided into 3 types. First is immediate or contact seizure, which occurs within 24 hours of injury. Early seizures occurs within 1 week of traumatic brain injury, and late, which occurs 1 week after the injury. Pathophysiology is due to the pathological changes that occurs in the brain post-trauma that can cause scarring or gliosis, which will reduce the seizure threshold, and further alcoholic consumption or reduced sleep and strenuous activity can further deteriorate the seizure threshold, and patient can have seizures.
So what are the triggers of seizure? You already told, but in a general patient with the seizure activity, you have to advise the patient to avoid such things. What are the triggers of seizure?
First, the patient might forget his medications.
So drug compliance is very important.
Yeah.
Second,
And if there is any change in dosage when patient was taking.
Change in reduction in dosage. Okay.
Or if the brand changes.
Okay, reduction dosage, reduction
alcoholic,
content of the alcohol. Okay. Then.
Strenuous activities, sleep deprivation.
Okay. Sleep is the most important thing. Then flashes of light. TV, flickering lights. All these things can sometimes.
And certain drugs like
fluoroquinolones. So other drugs which can induce seizure. Okay.
The risk factors for seizures post-traumatic brain injuries are depressed fractures, STH, EDH, ICH, penetrating injuries. Post-injury patient had a GCS less than 10, chronic alcohol consumption. And risk for recurrence of these seizures include alcohol abuse, drug non-compliance, more number of frequency of seizures more in first 1 year, and if it is a partial seizure. All this can cause increase in.
What is the difference between partial seizure and generalized seizure?
In generalized seizure, there is a deep stimuli which is coming out and involving the whole cerebral cortex.
So the full brain is involved in generalized seizure.
In partial, a part of the cerebral cortex.
Only one focus is producing seizure activities. Their loss of consciousness may not be there most of the time.
2 types, simple and complex. In simple, there is no loss of consciousness.
Most of the time, it will be simple and loss of consciousness and post-ictal confusion may not be there. But like you told, if it is a complex partial, then patient can lose the consciousness. Okay.
We had taken a CT brain to rule out any new bleed. A patient did not have any acute bleed. We had given injection thiamine 500 mg in 100 mg.
Why thiamine?
In alcohol.
Okay. Since patient is already taking alcohol, there is a chance of thiamine deficiency in that patient.
And Korsakoff's. And we also gave him Levipil 1.2 gram IV. Loading dose was given.
So what is the dose per kg body weight?
20 to 60 mg per kg.
Okay, 20 milligram per kg body weight. Okay. How do you manage a status epilepticus in emergency room?
Status
Tell the steps.
epilepticus is defined as a single seizure which is lasting for more than 5 minutes or 2 to 3 seizures without regaining consciousness.
Okay.
First, once the patient arrives, we have to put 2 IV. If the patient is actively seizing, we have to put him in left lateral position with his head down so that he won't aspirate.
Okay.
And we have to secure 2 IV bore cannulas and large IV cannulas, and we have
Large
to
bore
give
means
18 gauge.
18 gauge. Okay.
Then we have to supplement oxygen, and at the same time we have to find any reversible causes, electrolytic imbalances.
What is the most important? Glucose. So in emergency room, both seizure and seizure can produce hypoglycemia can produce seizure. Both are possible. So we have to, first of all, we have to check the sugar. Okay. Then only all other investigation comes. Okay.
And all other and
what are the other investigations you will tell?
Electrolytic
Sodium,
imbalances, sodium, calcium, magnesium,
phosphorus.
high phosphorus also
Then
can cause.
Ammonia.
Ammonia.
Where?
In CLD.
CLD. Okay. Hepatic encephalopathy. More in children, you check ammonia and ABG. What is the reason for that? Metabolic disorders. Okay, so that is not common in adult and not common in this type of patients. It is very, very common in children who is having recurrent seizures. Okay, metabolic disorders. In that case, you check the ammonia. Okay.
Then we start with IV lorazepam. First we can give 2 mg or can hike it up to 0.1 mg.
What are the
per
ways
kg.
you can give diazepam or diazepam derivatives in seizure patients? Because you can get
rectal can be given.
Okay, per rectal diazepam
IV,
can be given.
IM.
IV can be given. IM can be given. Then nasal spray. Which drug?
Lorazepam.
Which drug? It is available. Midazolam. Midazolam nasal spray is available. Okay, so most of the patients carry that. Okay, immediately you give 1 or 2 puffs, seizure can be controlled. Okay.
Either IV lorazepam or IV diazepam has to be given along with.
What is the difference between lorazepam, diazepam, midazolam, all these things? Is it all same? What is the difference? Diazepam. Duration of action is very long. Okay. Lorazepam is little short acting. Midazolam is ultra short acting. That's why we give midazolam as an infusion. Okay. Whenever we stop it, it is reversed. Okay.
Along with that, we have to give either IV phosphiniton, IV phenytoin, or levetiracetam.
There is a difference between phosphiniton and phenytoin. These all drugs are routinely used. Nowadays, we are not using, but it is routinely used and it is there in the guideline.
Phenytoin can cause cardiac side effects.
Phosphiniton also can produce.
Allergic.
Allergy is not very common.
Phenytoin has an extra.
You can give faster phosphiniton.
So phosphiniton can be given faster. Within 30 minutes you can give whatever dose you are calculating. Other one minimum 45 minutes. Phenytoin can be diluted in
DNS.
DNS. It can be diluted in dextrose water, whereas phenytoin
Cannot.
It can be diluted only in normal saline. Okay, so these are the advantages. Most of the seizures what we see, patient can have some hypoglycemia. So we prefer phosphiniton over phenytoin. We want to give it faster. We want to give it in dextrose solution. Then phosphiniton is better than phenytoin, but dose is almost same. Okay, difference between phosphiniton, phenytoin, and levetiracetam we have already told. The difference is mainly it can be used in multiple conditions without any major side effects. Okay.
If the seizures are refractory, happening more than 30 minutes, we have to secure airway.
Okay.
And start with either midazolam, propofol, or ketamine infusion.
Okay.
Midazolam 0.2 mg per kg infusion. Propofol has to be 1 mg per kg IV.
Okay.
Infusion. Ketamine 5 mg per kg IV infusion.
Then after that, do you want to do
Evaluate.
CT, MRI, EEG, drug levels, all these things.
Yes.
You want to see the drug levels in seizures?
Yes, sir.
Why?
To know whether the patient was compliant or not.
Okay. Can you tell me what is narrow therapeutic index?
When those
It's a basic pharmacology. Narrow therapeutic index.
when there is a narrow range for the
So
toxicity.
most of these drugs, phenytoin, phosphonatoin, phenobarbital, they all have a very narrow therapeutic index. If it is little lower, then it produces seizure. Little higher, it will produce toxic effects. Okay, and that is a problem of these drugs. They are very cheap, but this problem is so whenever patient is on some drugs, it is better to check the drug level and correct the treatment. If the drug level is very, very low, then you correct that drug. Unnecessarily adding another drug will not serve the purpose. So, drug levels are very important, especially when the patient is on chronically some drugs for seizures. Okay, so that is very important. Then CT, like you told, is CT is required in all patients with
and
seizure?
also already known case of seizures.
So
if there is any change in pattern of the seizure,
So
then
suppose it is a first time patient coming with seizure, imaging is required. Or like you told, change in pattern of seizure also, or increasing in frequency of seizure, we have to ask for a MRI or CT, whichever is required for that scenario. Okay, then EEG.
if it's more helpful in partial seizures, we'll get to know which lobe is producing.
Okay, some patients will be malingering. That is a problem. So in that case, video EEG will be very, very useful. Like seizure patients, they also can come with malingering. Okay, they'll act like they have seizures, but we will not have any evidence for seizure clinically. So you can, to confirm the thing, you can do EEG or video EEG to confirm this one. Otherwise, routine seizures, every time when they come back with seizure, it is not required. Only thing when the patient is admitted in ICU, like your patient who is not gaining consciousness after a head trauma, then to know whether a seizure is present or not, you can ask for a EEG. Okay, what is that called as? The patient is having seizure, but there is no physical seizure observed. Absent seizure in children, no?
Malingering, Martius syndrome.
Non-convulsive status. Okay. Non-convulsive status is a very common problem in ICUs, like especially after head trauma and we admit, no, patient will not regain the consciousness. So even if you withdraw all the drugs, patient will be unconscious. So in that case, you will have a doubt whether it is due to some head injury related problem or patient is having continuously throwing seizing activity. So if you do a EEG, if you are seeing generalized seizing activity in EEG, then you have to confirm that it is a non-convulsive status epilepticus. That you have to be very careful. Okay. What else you have taken care in this patient?
We took a neurology opinion.
Okay.
Because
other than that, not opinion. I am asking general measures to be done in a patient who is admitted in ICU. General measures.
Provide him with IV fluids. Then
IV fluid means what? What IV fluid do you want to give? What is IV fluid? She is telling IV fluid. Maintain. He is a normal adult, no? He requires calories. How do you calculate the calories? What is a required calorie for a patient who is admitted in ICU? Per kg body weight, how much? What is the required calories? 20 to 35 is a big range. 20 is very less. So at least 30 kilocalories you have to give. If the patient is very sick, critically ill, 40 kilocalories. That much you have to give, that much you have to calculate and give through whether it is IV fluid or Riles tube or oral, whatever way you want to give, you have to give. Okay. What is the current guidelines on feeding of patient in ICU? Is it early or late?
early.
Early feeding is better than late feeding. Okay.